Warm welcome to all of you. It is indeed a great pleasure for us to have Dr. Pankaj Goel G, as well as all of you attendees on this lovely luncheon webinar opportunity. Greetings from Group Pharmaceuticals. I am inviting all of you to snuggle into a great webinar. No, I am not asking you to sleep, but the concept is that we are going to talk something on related to sleep. Yes, the dentist of the day at today's luncheon webinar, Professor Dr. Goel Saab, will be presenting his views as well as the scientific evidence and very interesting concepts related to the role of dentist in diagnosis and management of obstructive sleep apnea. Oh, what an interesting topic, isn't it? Well, the dentist of the day, Professor Goel Saab, is the professor and head of dentistry at the All India Institute of Medical Sciences and Institute of National Importance, Government of India of Bhopal. However, before we launch into the actual webinar, here is a interesting slide deck on the science of pillows. It depends on basically whether you are a stomach sleeper, back sleeper, or side sleeper. If you are a stomach sleeper, then you have to go in for a medium firm pillow. Back sleepers can go from very soft to medium firm, and side sleepers choose a very soft to a medium pillow. Well, that's the science of pillows, but there's more to come. You may go in for a regular type pillow or a contour type pillow, peanut shaped pillow, or a functional A type pillow. There are so many types. In fact, the costliest of them all is the down pillow, which is made up of soft fibers close to the skin of a goose, duck, or swan blended with feathers. Oh, what a pillow it would be. But if you don't want or you cannot have a down pillow, then there is a down alternative pillow, which is a synthetic version. And most of these alternative pillows have a polyester that is used to mimic the feeling of the down pillow. And there is also the next level called as the feather pillow, which is a great traditional filling for those who get the support without losing the shape of the pillow. This is a comfortable and supportive option for particularly back and slide sleepers. The cotton pillows are something that we have all probably grown up with. So there are also the newer trends of synthetic materials now. Nevertheless, the cotton pillow is versatile, light, breathable, odor-free, and very versatile for side, back, and stomach sleepers. The latex pillow is now gaining popularity, particularly because it provides a good support for the head and the neck. But this is not recommended for the stomach pillow sleepers. The memory foam pillow is also now becoming popular because it contours to your body, meaning that it can be a good fit for all sleeping positions. But why is it that there is a name called memory foam? Well, this memory foam has the capability to bounce back very slowly, and over time, this sort of a fabric will remember your body shape and optimal sleeping position. This is why the name memory has been given to it. Then there is another concept, the bamboo pillows. This is a rising trend in the sleep industry and has antimicrobial and moisture absorbing abilities. Very interestingly, bamboo pillows are made from the bamboo viscose shell and has the benefit of a shredded memory foam pillow with the cooling properties of bamboo. And if you prefer, there is also the gel pillow. The gel pillow is basically to keep people cool at night. So it is combined with the foam, latex, and other kind of cool benefits of the gel, and there is the softness of another material. The polyester fiber fill pillows are also taking off because this is a budget conscious pillow, and this is due to the cheaper material of the polyfill which is used in these pillows. Then there is an interesting buckwheat pillow. Buckwheat is used basically for giving the body to the entire pillow, but this causes some sort of noise, and that is the reason why you got to be a little careful. It's better for the back and the stomach sleepers. Particularly, this buckwheat is in Hindi known as Kuttuka Atta, and in Kannada this is called Hudli. And probably this word will be liked by Dr. Goel Saab because he is an alumnus of Manipal College of Dental Sciences, so he would like that Kannada word Hurli also. The micro bead pillow is another type which makes the feeling that you get from the buckwheat pillow similar to that. And this is, however, made of synthetic material with uniform polymer materials. But there is another concept called as messenger pillows. So you can put the message on the pillow or the cushion, and this is also a great attraction. For example, these are the messenger pillows that I have found for the dentist. Here, the dentist's messenger pillow or the cushion is saying, I'm silently judging your teeth. And there is another interesting concept here where the greeting is, may the floss be with you. What an interesting statement, isn't it? Here we have an interesting statement which says, be nice to your dentist. They have fillings too. A kind of a pun, feeling and filling. Here is a good one. A truly amazing dentist is hard to find, difficult to part with, and impossible to forget. So very touching, isn't it? And life is better when you are a dentist. And last of all, nobody is perfect, but as a doctor, you are pretty damn close. Oh, so sweet of all these messages. So, learn to brush twice a day, says this pillow message. And what we reiterate, if it is the children, then please do recommend Pediflor Kids. The new orange flavor has also come. The sleep laboratory in Stockholm, Sweden says that sleep-deprived people appear less healthy, less attractive, and more tired compared with when they are well rested. So obviously, it is a beauty sleep all of us require. But there is also a concept of sleeping beauty syndrome, in which affects basically the adolescent males, characterized by recurrent episodes of hypersomnia, condition where there is excessive sleepiness during the day, and this may even occur after long stretches of sleep. These days we find the kids, especially when they have been playing all these video games, and we start wondering whether they are suffering from this sleeping beauty syndrome. So wake up and smell the coffee, because now we are up to the Dentist of the Day's webinar. Professor Pankaj Goel is here from All India Institute of Medical Sciences. He is also the alumnus of Manipal College of Dental Sciences. This Manipal College of Dental Sciences is a part of MAHE, which is a deemed university located in Manipal, with also campuses at Bangalore, Jamshedpur, Malacca, and Dubai, basically providing 350 programs across 30 disciplines and ranks 7th among the Indian universities, and a well-noted name, Manipal. Manipal College of Dental Sciences covers all aspects for grooming a student into a mature, knowledgeable, skillful, and responsive dentist. This institution also aims to promote research and innovation, which will motivate better learning and exchange of knowledge among students and faculties. In fact, Dr. Kirtilata M.Pai, who is the Dean of MCOTS Manipal, reiterates, we are proud of our alumni who are holding the flag of our college high. All over the world, many of our alumni have become vice chancellors, deans, and have occupied other key positions globally. So this is the sentiment with which Manipal works. And to this genre or to this category, we have Professor Pankaj Goel, who is holding an important post at the Institute of National Importance, making his entire family, his alumnus, and his colleagues, peers very proud. Dr. Pankaj Goel sir has studied at the high school from Jakarta International School in Indonesia. His middle school was at the École Internationale de Paris, and then he joined after the various educational pursuits, qualified for BDS and MDS. His MDS has been in public health dentistry and postgraduate diploma in health management from the National Institute of Health and Family Welfare, New Delhi, India. He worked for a short time at Manipal College of Dental Sciences in Bangalore. From there, he went to Maulana Azad Medical College, New Delhi. He has served with DJ College of Sciences, Modinagar, India, as a professor and HOD. From there, he went to Al Fateh Medical University, Tripoli, Libya, as an associate professor. Then on to People's University, Bhopal. He was the founder principal of Rajendra Institute of Medical Sciences in Ranchi, which speaks a lot about his administrative capacity and also his scholarship. And currently, he is with the All India Institute of Medical Sciences, Bhopal. A wonderful career track record reflecting his scholarship, administrative abilities, and zeal to always achieve the next level, which is reflected in his 35 research publications under the name Goel P, which is common in all his research publications. For example, you have a study, Prevalence of Dental Diseases among us 5 to 6 and 12 to 13 years old school children of Puttur municipality. There is another one which has been conducted to find out the knowledge, attitude, and practice of dental caries and periodontal disease among the primary school teachers in Udupi municipality. The excision of oral submucous fibrosis and reconstruction with full thickness skin graft, a wonderfully scientific activity there. Role of dentist in genetic counseling, and interestingly, oral health related knowledge, attitude, practices among the eunuchs. So what a wide variety. Then there is also stem cell research for cellular therapeutics and regeneration. And this is a very interesting one. Effect of different sweets of Indian staple diet on salivary acidogenicity. I think that can be, a topic for an entire webinar. Everybody would be interested in that. And Dr. Pankaj Goel has authored or co-authored several textbooks. Goel P, this textbook is on preventive dentistry and dental statistics. You have a textbook on health education. You have another one on oral health and dental hygiene with another individual. So you have got so many interesting books that you can go through for your own learnings. Interesting, Dr. Pankaj Goel is a patent holder. I have shared the PDF of the patent details here. It is on self-operable mandibular advancement device, SOMAD. This is something very interesting and motivating to all the dentists. And finally, we see an interesting set of photos. Here he is happy to release or gift this textbook written by him. Dr. Goel is addressing the state medical officers and participating in a faculty development talk. He is receiving an award here as the founder principal of AIIMS RIMS Ranchi. So obviously, these are all very memorable milestones in his life, and a guest lecture at ESI is the icing on the cake. So we at Group Pharma, we present several interesting products for patronage by dentists. Thank you very much, doctors, because these pastes or oral care products are always tied up with dental procedures, either before, during, or after the dental chair side procedure. And Pediflor is, of course, a very popular one for the gum health as well as the health of the enamel in pediatric cases. And for protection from COVID-19, reliance is on Omnident, which is an excellent toothpaste to reduce the gum line inflammation. Fresh Chlor reduces the viral load in your patient, so you are safe from any kind of viral microbial attack. We offer world-class manufacturing at Group Pharmaceuticals. We have 3 manufacturing units, and we supply our products across 60 export destinations. There are several interesting and important certifications which reflect the competence in manufacturing of Group Pharmaceuticals. We are also happy to announce the different certificates that we have to indicate the manufacturing competence and expertise. So these are some interesting concepts. Our dedication to CSR is also there. That is the community service that we do as a corporate social responsibility. Recently, the novelty that has been introduced, Densive, is very popular, particularly to improve the oral denture habit. Hygiene is much improved because of Densive. So we partner dentists to create a world full of healthy smiles and laughter. Dentists make you laugh and smile without hesitation and also relieve the pain. So thank you very much. And now over to Dr. Pankaj Goel, sir, for a fantastic webinar. Thank you very much.
Good afternoon, friends. Myself, Professor Pankaj Goel, and today I'll be talking to you all about a highly neglected area, especially among the dental fraternity, which has got tremendous need as well as potential in the current era for management, which is the topic on obstructive sleep apnea and the role of the dental personnel in its management. Starting with the understanding of obstructive sleep apnea, the most common condition with which we all relate to is snoring. And snoring may be a cardinal sign or may lead to a much more serious condition, which is called as obstructive sleep apnea. To understand the actual definition of obstructive sleep apnea, which is referred to as OSA, it is a chronic sleep-related breathing disorder that affects about 2 to 4% of the population worldwide, which literally translates into hundreds of crores of people throughout the world. The peculiar thing about obstructive sleep apnea is that it occurs at time of sleep. So most of us do not feel that we have any kind of a problem as far as breathing disorder is concerned while we are awake. Unfortunately, when this obstruction of the upper airway at sleep time progresses, it starts interfering even with our daytime activities. Untreated obstructive sleep apnea has been associated with long-term health hazards that includes hypertension, diabetes type 2, congestive heart failure, arrhythmias, impaired neurocognitive function, and eventually a decreased quality of life. A much more serious complication of untreated obstructive sleep apnea of the severe variety is eventually death. Now, why does obstructive sleep apnea occur in some people while it does not occur in others? As we all know, when we are awake, our normal upper airway and neuromuscular compensation is well adjusted. However, when we are sleeping, the breathing activity, that is inspiration and expiration, decreases by almost 33%. And this is predominantly because of a reduced pharyngeal muscle activity and loss of the neuromuscular compensation. In some people, because of a physical obstruction in the airway, or maybe by the CNS or the central nervous system, the inspiration of air decreases to an extent that it causes apnea. This apnea or cessation of breathing causes an airway collapse, and there is decreased oxygen availability in the body, which is hypoxia, and an increase in the carbon dioxide, which is hypercapnia. As a result of this, the body makes an enhanced ventilatory effort to compensate for the hypoxia and hypercapnia. And because of this physical obstruction in the airway, or because of the collapse of the airway, a person gets up gasping for air, thereby reopening the airway and restoring the pharyngeal muscle activity, which leads to a period of hyperventilation initially that corrects this hypoxia and hypercapnia, and the person goes back to sleep. Now, this cycle of airway collapse, enhanced ventilatory effort, arousal from sleep, hyperventilation, and going back to sleep is something which occurs at times with all of us and is considered normal. However, when this occurs several times at night and over a period of several days, months, or years, and progressively worsens, that is a stage when we refer to it as obstructive sleep apnea. Looking at the classification of sleep disorders, some of the terms which we as dentists are very familiar with is, for example, insomnia. Now, insomnia, or the inability to sleep, can be caused due to multiple conditions: stress, certain medicines, food habits, and is something which we feel can also occur naturally on certain days. Another term which we are familiar with is hypersomnia, which we see very often nowadays. That is people who work at night in BPOs and companies who tend to sleep excessively during daytime, and that is hypersomnia. It can also be an indication of an underlying disease or depression, or maybe a faulty lifestyle. Then we have parasomnias or associated things at sleep time, such as good or bad, whatever you like to call it as, maybe a nightmare or maybe a dream. However, sleep-related breathing disorders do not occur in any of these conditions. It itself or by itself is an entity, predominantly classified into two: one, obstructive sleep apnea, and two, central sleep apnea. Like I was mentioning earlier, obstructive sleep apnea is due to an actual obstruction in the airway due to a physical pathology maybe, while a central sleep apnea is not due to an obstruction in the airway but is mediated centrally. The discussion for today's topic is restricted to obstructive sleep apnea because that is where the dental surgeons can play a role. Looking at this particular picture, as you can visualize in the first picture, A, this is what we refer to as a normal airway, which is a person is able to breathe in, breathe out through the nose, as well as from the mouth. However, in picture B, as you can see, there is a collapse on the airway, maybe because of enlarged tongue or maybe because of an enlarged uvula, for example, and there is no space for the air to enter into the oropharynx due to this physical obstruction. Similarly, or simultaneously, there could also be a blockage in the nasal passage, thereby, again, preventing a person from breathing in and out. Obviously, the prevalence varies with gender. As we can see in this slide, many more men as compared to women are affected by obstructive sleep apnea. And globally, about 100 crore people, and in India alone, more than 5 crore people are affected with obstructive sleep apnea. The risk factors linked to obstructive sleep apnea, besides the male gender, is the age. Obstructive sleep apnea is seen to progress with age, and many more people in the older age group suffer from obstructive sleep apnea vis-a-vis the young ones. However, this is not to say that obstructive sleep apnea does not occur in children. It can very well occur at any age group. Pregnancy is a condition again linked with an increased probability of obstructive sleep apnea. Very strong evidence is available in literature regarding the association between obesity and obstructive sleep apnea. Anybody who is overweight or obese has a much higher risk for developing obstructive sleep apnea. This can be measured by the BMI or the neck circumference. And it is said that any female having a neck circumference of more than 16 inches and any male having a neck circumference of more than 17 inches are particularly vulnerable to developing obstructive sleep apnea. As I was mentioning, an enlarged tongue or tonsil, as well as a retroposed mandible or maxilla, or a small mandible vis-a-vis the maxilla, are again very strongly linked with a higher chance of occurrence of obstructive sleep apnea. And then there are obviously certain specific syndromes like the Pierre-Robin syndrome, the Treacher-Collins syndrome, which have a role to play in causing obstructive sleep apnea. There are certain suspected risk factors, predominantly tobacco smoking and alcohol use, which may be associated with obstructive sleep apnea. Certain drugs like muscle relaxants, Down syndrome, menopause are some of the other conditions where there are chances of developing obstructive sleep apnea. Now, how does obstructive sleep apnea manifest itself? Most of the times, as I said, snoring is one of the cardinal features of obstructive sleep apnea. However, it's important here to mention that not every snorer has obstructive sleep apnea, although most snorers, or almost every snorer, would be a potential patient of obstructive sleep apnea. So we have to rule out the difference between obstructive sleep apnea and snoring, which I will do in my next slide. However, just to understand very quickly other symptoms of OSA besides snoring, as I said, the continuous break in sleep at night leading to a non-refreshing sleep is one of the very, very common symptoms of obstructive sleep apnea. And maybe as a result of this, a person has morning headache, irritability, excessive daytime sleepiness, as well as nocturia at night. Fatigue sets in as a result of this, and these are the signs which a dentist should be on the lookout for in case he suspects that his or her patient could be a case of obstructive sleep apnea. Now, in most dental practices, the patient would come with vague symptoms of obstructive sleep apnea. That is to say that patients will not come and complain to a dentist, especially that, doctor, I am not able to sleep at night, or I have this difficulty at sleeping due to constant frequent breaks. However, certain complaints of the patient, I can quote my own example, wherein I had a patient who came to me with a complaint of morning headache, which, as I said, is not a definitive diagnostic criteria, but is an indication that a person may have obstructive sleep apnea when there is nothing else manifesting organically. So in that particular patient, she was a female patient, middle-aged female patient, who had this complaint of headache, wanted me to extract one of her upper teeth, saying that she feels or she believes that it is because of the tooth that she has this headache. On doing a thorough clinical examination and radiographic investigation, I could not find anything wrong with the tooth. So I advised her that this may not be a solution to her problem, to which she said that earlier on another occasion, she had got one of her teeth extracted elsewhere, and she got momentary relief or temporary relief for a few days from her headache, which has again come back. So that is the reason she feels removing a tooth helps her. Obviously, we did not remove the tooth, and we were searching for reasons for headache as diverse as migraine. And it was a chance finding that I stumbled upon the fact that OSA could be one of the reasons. And upon more thorough screening, it was revealed that it was OSA, which led to that complaint of morning headache. So, like I said, patients may not come to a dentist for treatment of OSA, but since there is so little awareness or sensitization about this disease or condition, the dentist, being oral physicians, are in a very peculiar position to identify this condition. It starts with something as simple as a screening questionnaire, which is a very popular one known as the Upworth Sleepiness Scale, where we ask the patient that what are the chances of his or her dozing while doing one or more of these 9 activities. For example, sitting and reading, what are the chances of dozing? What are the chances of dozing while watching television? Chances of dozing while sitting inactively, maybe at a movie? Chances of dozing while being a passenger in a car for traveling for about an hour without a break? Chances of dozing when lying down to rest in the afternoon? Chances of dozing while sitting and talking to somebody? Chances of dozing while sitting quietly after lunch without alcohol? And chances of dozing when stopping at a light or in traffic at the time of being in the driver's seat. So depending on the chances, which is graded as 0, would never doze, or 1 as slight chance of dozing, 2 with moderate chance of dozing, and 3 as high chance of dozing, any overall score more than 9 on this screening scale indicates that the patient may have obstructive sleep apnea and warrants further investigation. Now, like I said, snoring is almost always associated with sleep apnea, but snoring by itself may or may not be a sign of sleep apnea every time. So let's have a look at what is the difference between the two. Snoring is something, if I may put it very simply for your understanding, snoring is something which troubles your partner, your spouse maybe, who sleeps with you, more than it troubles you, because of all the loud noise which we make at the time of sleeping. However, sleep apnea troubles the patient much more than it troubles the partner. That is to say that this constant break in sleep, like I was talking about, patient getting up, gasping for air, troubles him to a much greater extent, while as compared to snoring, which would be, if I may say, a very innocent symptom by itself. So anything which disturbs the sleep, causing a condition where there is apnea or hypopnea several times at night, qualifies as sleep apnea, while simple snoring without a break in sleep or without causing apnea and hypopnea repeatedly would not qualify as obstructive sleep apnea. Snoring and sleep apnea, and the predominant difference, like I said, was the fact that in snoring we do not tend to as snorers don't realize that we snore. It's our partner who does. But as sleep apnea patients, we are the ones who get up gasping for air, and that is the main differentiating point, as in the apnea and the hypopnea events which occur at the time of sleep. So in a normal sleep, like I said, there are times when one does have a complete or partial stoppage of breathing, which we refer to as apnea hypopnea index, and up to 5 times at night. This is considered as normal sleep. We may not even realize that we had this kind of an episode. But if the frequency of the episode goes up more than 5, then obviously it would be categorized as suffering from obstructive sleep apnea. Whether mild, moderate, or severe depends on the frequency of apnea hypopnea events at night. Now, how to measure this? So like I said, for a dentist, on the preliminary examination or screening of the patients, if you realize that the patient has had some amount of symptoms or signs of obstructive sleep apnea, for example, the Epworth sleepiness scale indicates that he may be a sufferer. The best thing to do is to refer the patient to a chest physician or a general physician for assessing the apnea hypopnea events, which are done using sleep studies in sleep labs. And the most standardized or golden standard is the polysomnography. This is a lab investigation which measures at least 7 parameters. the EEG, EOG, EMG, ECG, airflow, respiratory effort, and oxygen saturation. Since this may not be available in all places, there are other levels of sleep studies using lesser equipment, such as a portable polysomnography machine, or maybe just a cardiorespiratory sleep study using portable sleep apnea testing of just 4 parameters, or just maybe a single parameter like the oxygen saturation, which can be measured at night by a trained health worker, or maybe by a family member who is trained to record oxygen saturation, especially now in post-COVID era. Most of us are well aware of the importance of oxygen saturation, and the machines are easily available. So the episodes wherein the oxygen saturation falls below normal, the number of times it does at night, would be an indicator of the severity of sleep apnea as mild, moderate, or severe. So that is talking about the sleep studies which are done by physicians. But dentists at their level, as oral physicians, can assess for other signs of obstructive sleep apnea, if I use the term oral manifestations of obstructive sleep apnea, by looking thoroughly into the mouth. And one of the predominant things to look for is the tongue and the position of the mandible. As I was referring to earlier, the blockage in the airway is basically when the tongue falls back at night time. And if a person has an enlarged tongue, then the potential for obstruction obviously is higher. Similarly, if the mandible is retrograded vis-a-vis the maxilla, the potential for obstructive sleep apnea is higher. And similarly, uvula, which if enlarged or inflamed, is again a reason where the obstruction to the airway can occur. And these features can be clinically assessed by a dentist very easily. A trained dentist can look into the mouth and see whether there is sufficient airway passage using what we call as the Malampati score. Now, this score, traditionally used by anesthetists, has been modified in this context, wherein class 1, as you can see on the slide, shows that there is sufficient airway passage, the uvula is fully visible, the tongue is not enlarged, tonsils are not enlarged, and the soft palate has not drooped. In class 2, which we may relate to mild forms of obstructive sleep apnea, the soft palate and the appears little drooped, and the uvula is visible but partially embedded in beneath the tongue, appears so. So this shows that the airway passage is a little below what would consider as normal. In a class 3, which we could relate to moderate sleep apnea, the uvula is hardly visible and the tongue may be enlarged. So again, the obstruction is higher here. And then obviously in class 4, the uvula is not at all visible and the tongue is definitely very big in size. And this could relate with what we call as severe forms of obstructive sleep apnea. So the Malampati score can be very nicely assessed by dentists who are trained oral physicians. A lateral cephalogram could be one of the investigations that can be prescribed by dentists. And in a lateral ceph, it is basically the relationship between the hyoid bone and the mandibular plane, which measures the severity or extent of obstructive sleep apnea. So the greater the angle, that is the lower the hyoid bone forming an angle with the mandibular plane, the higher the chances or severity of obstructive sleep apnea. So this could be an investigation which could be further prescribed. Now, coming to the management part. So this was the diagnosis part, how a dentist can very easily help diagnose obstructive sleep apnea and understand his important or pivotal role in screening for obstructive sleep apnea. Next is the treatment which may be prescribed. So generally we start with what we call as conservative treatment methodologies. And one of the easiest said, but most, I should not say easiest done, is to lose weight. So like I was saying, obesity or neck circumference is one of the important indicators of obstructive sleep apnea, and one of the important advice first would be to lose some weight. Obviously, dietitians can play a role here as well. Another would be to avoid alcohol, avoid tobacco, which are overall also very, very standard advice for patients, can help in management of obstructive sleep apnea. Another important advice would be to change the position. Sunilji was very nicely talking about the pillows, sleeping on the stomach and the back. Yes, it's important, Sunilji, and I think he said a very important thing, because sleeping in lateral position, left lateral, right lateral, doesn't matter, is going to help in decreasing the symptoms of obstructive sleep apnea vis-a-vis sleeping head down or face up. So sleeping in lateral position helps manage obstructive sleep apnea. So that was a conservative management. Looking at the medicinal management, so like I said, nasopharyngeal blockages can be there because of, for example, deviated nasal septum, or maybe because of allergic rhinitis, or maybe because of systemic or medical conditions like hypothyroidism or acromegaly. So treatment of those diseases would help in management of obstructive sleep apnea. Nasal decongestants, nasal corticosteroids are probably the first line of treatment. ENT physicians also prefer to give for people who come to them with obstructive sleep apnea. However, the golden standard remains the CPAP, or what we call as the continuous positive airway pressure, which is application of a device over the neck, over the nose and the mouth, which continuously pushes air at the time of sleep through the nasal and the oral passages, and helps the patient sleep because there is no block or obstruction because of this continuous positive airway pressure. However, like I said, again, something easier said than done. To wear a mask overnight may not be a very comforting idea for many patients. So one important thing which we are going to talk about today is the use of oral appliances, which is much less invasive or threatening, much more comfortable vis-a-vis a CPAP, and something which dentists can do, being a non-invasive form of therapy to treat obstructive sleep apnea. So before I go to the oral appliances, very quickly looking at the other modalities besides medicinal management is the surgical management of obstructive sleep apnea. So in moderate or severe cases, because when we talk about oral appliances and stuff, we are talking mainly about mild to moderate levels of obstructive sleep apnea. But with severe forms of obstructive sleep apnea, especially oral appliances may not work, and other medicinal therapies may not work. So it may be important to actually do a surgical removal of the blockage, such as nasal or uvuloplasty procedures. Simplest procedure being tracheostomy, although not very aesthetic and not something very comforting for the patient. Maxillomandibular advancement, like I said, a retrograded mandible is a risk factor. So maxillomandibular advancement is another surgery which can be performed. And then we have now experimental methods such as pharyngeal pacing and things which are showing promising results. Now, concentrating especially on the role of dentists, non-invasive management or medicinal management is the role of oral appliances in management of mild to moderate obstructive sleep apnea. This is referred to as oral appliance therapy, much less done because of the because I should say not only among the patients, because of the much less level of awareness or training within even the dental community about this kind of an appliance. We should have a little thought about three predominant types of appliances which can manage obstructive sleep apnea. The most popular being the mandibular advancement device, or the mandibular advancement appliance as it is known, which helps to protrude the tongue along with the mandible anteriorly at sleep time, so that the obstruction to the oropharynx can be reduced. Another way to do it is by retaining the tongue so that it does not fall back, and this is called as a tongue retainer appliance. Another is to hold the soft palate in position so that it doesn't droop, and that's called as soft palate lifter. So among the three of them, mandibular advancement device is perhaps the most reported in literature and considered better. However, even tongue retainer appliances or soft palate lifters or hybrid appliances have been tested and have given encouraging results. Uh, in this particular slide, I am making an effort to impress upon all of you the extent to which the mandible can be protruded from A to B, and this can be measured using the gauge. And an appliance can be prepared, a monoblock or a twin block appliance, which the patient would need to wear at night so as to keep the mandible in this position, in the forward position. Now, the obviously, as you can imagine, it takes time to acclimatize. It may be discomforting for the patient initially. So this advancement is not made 100% right at the beginning, and it is titrated. That means multiple appliances may need to be given over an 8-week period with that is gradual, progressive, incremental advancement of the mandible with each appliance till the patient is able to achieve optimum opening of the oropharynx. And this is generally done at recalls of 2 weeks, 4 weeks, and every 6 months thereafter, if required. However, the appliance will need to be worn long term, maybe throughout life, in case the patient is happy with it and the level of obstruction is greater. However, over 8 weeks, patients tend to have an acceptable level of sleep with minimal obstruction. So that is the standard protocol. Obviously, people who are edentulous or have advanced forms of periodontitis will not be able to use this appliance, and even with patients with temporomandibular dysfunction would also not be able to use it for simple reason that it would worsen their condition by wearing this particular appliance. So better results can then be also achieved by other forms, like I was talking about tongue retainer and soft palate lifter appliance. They can be tested. However, it is seen that anybody with a short soft palate length and a small mandible tends to benefit more from mandibular advancement devices vis-a-vis others. In this particular slide, I'm comparing the golden standard, which is the CPAP, with the oral appliance therapy. So like I was mentioning earlier, the CPAP, although the gold standard, even for advanced or severe forms of obstructive sleep apnea, has got several side effects. One is obviously the discomfort of wearing the mask, but in addition to that, dry nasal passages, rhinorrhea, congestion of the throat, air leaking from the mask, and the high cost limit the utilization of CPAP. As compared to that, mandibular advancement device or other oral appliances do not have those disadvantages. Nevertheless, excessive salivation, tongue abrasion, some mild amount of TMJ pain or oral mucosal dryness, some amount of occlusal disturbances or changes, and restriction in the level of jaw movement at night are some of the reported side effects with oral appliances. However, they are not so great or not so severe, I should say, that and a patient gets acclimatized to them over a period of time, so as we can warrant them, and that those are not absolute contraindications. So the side effects, nevertheless, are with any appliance, as you can see here. And the advantage of oral appliances vis-a-vis CPAP is that though, like I said, CPAP can be used even in severe cases where oral appliances can be used, whereas oral appliances can be used only in mild and moderate cases. The efficacy may be lesser with oral appliances. The adherence is greater because of the less side effects. While with the CPAP, the efficacy may be greater, but the adherence is lower. So a healthy combination of both maybe would be something which would be in everybody's benefit. I myself have applied for a patent wherein we have developed an innovative appliance along with my fellow friend Dr. Atul Gaur from the UK, where we have tried to overcome some of the limitations of oral appliance, so as to say the side effects, wherein the appliance would be self-operable by the patient to achieve an optimum level of comfort. So I invite those of you who are listening here or your friends who might be interested, in case you would like to use our appliance, I invite you to come forward and contact us by mail or telephone, which will be shared with you shortly, uh, and see if patients can benefit from this novel appliance in management of mild to moderate obstructive sleep apnea. With this, I come to the end of my presentation. But before we move, so as to say, I would like to pay my sincere regards to Bappi Lahiri, one of the iconic figures of Indian cinema, who unfortunately succumbed to obstructive sleep apnea. So, looking at the severity of obstructive sleep apnea, you can imagine that it is something which, if left untreated, can cause untimely death. So, please, thank you once again for a very, very patient hearing. And I hope that I have been able to touch this topic, which is largely neglected or maybe not given the due which it should in today's modern era, wherein we find more and more people because of unhealthy lifestyles succumbing to obstructive sleep apnea as an emerging uh, epidemic. Thank you once again.
Thank you so much, sir. You can stop the sharing, and congratulations, because this webinar was extremely interesting. There is a outpouring of questions which indicates the level of engagement. So if you don't mind, I will start asking these questions. I will start with what I consider as a very interesting question by Dr. Meenakshi of JSS Dental College, Mysore. Are there salivary markers to diagnose OSA?
Okay, that's a very interesting question, Dr. Meenakshi. Uh, Salivary markers to measure obstructive sleep apnea is definitely an area of research. Salivary markers by themselves are very, very promising indicators of several diseases, and many of them have actually now come to the level of commercial availability. However, with obstructive sleep apnea, as far as India is concerned, we still do not have something which is in public domain. They may be available at an institutional or academic or research level. So, obstructive sleep apnea, as in the salivary changes it will cause, definitely is very much, I would say, required armamentarium, which would further enhance the diagnosis or screening for obstructive sleep apnea. Unfortunately, like I said, in India, it is not so popular. And definitely we would need to work further on this so as to limit the cost of the investigation, and at the same time disseminate the availability of this particular test.
Thank you, sir. And another interesting question, three or four. I know that it's high time attendees, that it's lunchtime, but still some good food for thought is available here. Dr. Deeksha madam wants to know, what is the role of nasal polyps in obstructive sleep apnea?
Okay. See, any form of blockage of the nasopharynx is something which will induce exerted breathing, and snoring, for example, is definitely one of the, like I said, cardinal features here. So with the nasal polyp, definitely we can expect that the patient would snore. Whether it will progress all the way so as to cause obstructive sleep apnea is not something which I would stand by, because there are see, please understand that if there is a nasopharyngeal blockage, snoring definitely occurs, but the patient always involuntarily tends to breathe by mouth. So in case there is no obstruction of the oropharynx, if there is an associated concomitant obstruction of the oropharynx along with nasopharynx, definitely it will lead to episodes of apnea hypopnea at a much higher level or much more frequency, which can be associated with obstructive sleep apnea. However, nasal polyp by themselves may not alone be sufficient for qualifying a patient as suffering from obstructive sleep apnea.
Yeah, thank you, sir. I think doctors are in a hurry to meet the other because somebody is asking whether there will be a pause. No, we are closing in a few minutes, madam. Just one or two questions and then we will close. Dr. Rekha Shetty, madam, has an interesting insight. She wants you to give the information why men snore more than women.
Okay, that's very interesting. Yes, men have many more problems than women, overall, as far as lifestyles go. Jokes apart, one of the things which we can associate the male gender with obstructive sleep apnea is the suspected risk of higher frequency of smoking, higher frequency of alcohol consumption among the males vis-a-vis the females. So those are the suspected risk factors which can affect the male population, rendering them at a higher vulnerability for obstructive sleep apnea. As far as the genetic predisposition is concerned, if you are looking into that, I think it is an area of further investigation, an area of further study, whether genetically males are predisposed to obstructive sleep apnea. As far as the oral structures are concerned, it is the tongue or the mandible. I'm not very sure whether retrograded mandible or enlarged tongue is found to a higher in a higher frequency among the males. I don't think there is any such reported definitive evidence in literature, but definitely, like I said, it would be an area of study that why males are more at risk, and suspected risk factor is something which I would vouch for, habits, as to say, or lifestyle habits, to make it very, very specific.
Yes, doctor. So I'll take only two more questions and close it here. Attendees, please. So Dr. Anita Shivram has a very interesting question. Does mouth breathing have any association with OSA?
Mouth breathing. Okay. Generally, okay, I will come back to one question Dr. Meenakshi was asking earlier, if I got the name right. That is the role of nasal polyp. So generally,
that was Dr. Diksha. Okay,
Dr. Diksha, sorry.
Continue.
Yes.
Yeah.
So when a child, especially among children, we find that the nasal polyps, tonsils, and such tonsillitis and certain such medical conditions are more common. The child tends to by default start breathing from the mouth. So that leads to obviously certain kinds of malocclusions, which are well reported in literature. However, obstructive sleep apnea as a result of mouth breathing is again something which is not reported. So what the point I'm trying to make here is that all your questions are very, very valid. However, there is no definite evidence for these things. And mouth breathing would render a person prone to obstructive sleep apnea is debatable, because when we are talking about mouth breathing, we are not talking about obstructive sleep apnea. We are talking about an obstruction in mouth breathing when we are talking about obstructive sleep apnea. So mouth breathing per se may not cause obstructive sleep apnea, but obviously nasal polyps would by default cause the child to breathe by mouth is definitely well established.
Okay, sir. Last question. Dr. Kavita wanted to know, generally speaking, she's a practicing doctor. So how important is sleep per se as such for a dental patient?
I think sleep is important for every patient, not only for a dental patient. Like I said, my own example, which I gave you, how I got close to this topic. One is I myself had a period of obstructive sleep apnea. That was one. Another was the nature of the complaint of the patient. Like I said, nobody is going to come to a dental clinic saying that I have difficulty sleeping, doctor. No, they will not come to a dentist for that. They will come to you, like I said, with a complaint which I had from the patient of headache, because they feel that maybe it is related to their teeth. somehow that is causing some pain, and maybe there could be an associated carious tooth. That may not be the reason for obstructive sleep apnea, but that could be the starting point for you. Spouse may suddenly say, my spouse snores a lot, I find it very difficult to sleep, and he gets up at night and stuff. So see, what I'm saying here is, this is what we call as opportunistic screening. The dentist being or having ready access to the oral cavity, do not consider OSA as being in their domain. Now, that is what I'm trying to break here. Please understand that if you have checked all the teeth, you have checked all the oral structures, and there is no reason why the person is having headache. It could be purely a neuro condition, no doubt about it. But why not suspect OSA? And why not look into it a little further? Because like I said, crores of people are suffering from it. They do not know the condition. They never report it to the doctors. I'm not very sure how many physicians actually are trained to look into OSA. But dentists definitely being so having such ready access to the oral cavity can definitely look for signs in the oral cavity, can definitely do some initial screening, and you may be able to help the patient in a big way. So yes, Dr. Kavita, patient will not come to you with a complaint of not being able to sleep at night, but during the process of history taking, or even the complaint per se may be associated to this. So please keep an eye for it. That's all that I want to say.
Yeah, perfect, sir. I think it is not that OSA is only for the people who are intellectually backward. I think anybody can suffer from OSA, because there was a remark that probably people who are intellectually backward, they may be having more amount of mouth breathing or OSA problem. I don't think any such associations are there. So, Doctor, I think we have come to the final leg. It's just that we would like to thank, first of all the attendees, particularly from JSS, from Manipal, and also from Oman, Dubai, and Qatar, one or two doctors who have joined in, and from Saudi, one doctor who had joined in. And also we had some doctors joining in from North India, particularly the colleges you are associated with. So we thank all of them to have come in here. And my special thanks to you, Dr. Goel sir, for this very scholarly rendering and eloquent talk with a very good presentation on the subject of OSA. So with this, I take your permission to close this webinar. May I close the webinar, sir?
Please, sir. And thank you so much. Thank you so much.
Thank you so much.